I'm a chest doctor. That's my main job, full time, okay? It's not like being a clinical e-health lead is a hobby. It's just as important, but first and foremost, I'm a clinician. And so I got involved in this as a clinician because things needed to get better. It was really tough working with what we had to work with in terms of technology, in terms of information, and I'll touch on this. Portal-to-portal sharing is what the title of this talk is, but what it really is looking about information, and it's information that we're sharing. There is this idea that a radiology result, a lab result, these are all things, entities, but it's just information. And once we get beyond that, then we're going to really start moving with things. Ian's concepts of talking about data and analytics really cuts to the core of that. How we can look at information, how we can utilize it in planning, but also for patient care as the first and foremost. So what does it mean to share? So it's a kind of quid pro quo. So what we're talking about is taking pieces of information from one health board to another because we need to. And I'll touch on why we need to do this. But it really is about how we can improve the care for our patients and quickly and effectively. We heard examples from Ireland how you can actually get that cancer diagnosis or that freedom from cancer diagnosis done as quickly as possible because you've got access to that information. And it's not just about treating patients, it's also about removing the anxieties that are associated with the possibilities of what are life-threatening conditions. I deal with that on a day-to-day basis because as a chest physician in Scotland, a bit different from down south is I deal with interstitial lung disease, which is a terminal condition. I deal with lung cancer, which is a terminal condition. I deal with COPD, which is a terminal condition in its advanced stages. So it's really very important for patients and it's very real. So a little bit of background. We have 14 territorial boards in Scotland. The areas we're talking about here is we've got Greater Glasgow and Clyde. So together the population is about a third of Scotland. First, third, and that's the second largest board in Lothian. We've got Dumfries and Galloway down at the bottom here. Sorry, that's borders. Dumfries and Galloway, and Ayrshire and Arran there. These are all, hopefully in the future, become amalgamated into a single West of Scotland portal. We certainly got Dumfries and Galloway on the page just now. So you're talking about quite a population of Scotland. I know in terms of England and the UK, it's not a huge population, but it is a large geographical area across Scotland that we're trying to deliver healthcare. In my locality, that's where I work. That's East Kilbride, that's Hairmars Hospital, DGH Hospital, about 250,000 people, not big. Wishaw, and that's Monklands Hospital there. That's the 3 hospitals in our health board. We're all linked up, we're all on the same portal, easy. If we move between those hospitals, fantastic. This is when it gets a bit tricky, right? This is the Greater Glasgow area. Now, you've got Glasgow Royal Infirmary, next hospital there is Monklands. You've got an interface here where there's a bit of flow in between. You've got Queen Elizabeth University Hospital. That's our super hospital. I won't say it's called the Death, well, it is called the Death Star. It looks like a Death Star. It is kind of this trifoil thing. Yeah, and shuttles land on the top. Yeah, it's the whole thing. This is Victoria Infirmary, or the new Victoria Infirmary, which is now an ACAT. It used to be an acute receiving hospital. It isn't anymore. All the patients from this area here are meant to go to there. Okay? See where I'm going with this? A lot of those patients don't want to go to there. Parking's rubbish and it's quite a distance. Hey, parking's great. Easy to get to. There's Clarkston, Busby. The cut-off is about here, okay? It kind of goes up and round and round and up and round like that. It's a very odd boundary. But patients will vote with their feet. You can tell them go to this hospital, not that hospital. They don't care. If I can park and I get seen, I'll go there. So we have these in blue here. That's Paisley. These are all acute hospitals. In blue we have the Golden Jubilee National Hospital, Waiting Times Hospital. The importance to me as a chest physician is the thoracic surgeons live there. And that's where we send our patients for thoracic surgery. Beatson Oncology Centre. Importance to me is the PET scanner sits there. So if I'm doing lung cancer management, I need to be able to have access to that. Thoracic surgeons do operations and biopsies. So where does their pathology go? Not to the Golden Jubilee. It goes to Queen Elizabeth University Hospital. Golden Jubilee is a board in itself. It's a special board. So they have a different arrangement for IT. Sally will speak about that later. But they've got clinical portal. And this is the key. So I'll go through some patient cases which I've redacted and I've also modified for confidentiality. So why is it important to share? The complexity of cases has gone through the roof. So lung cancer cases, even 5 or 6 years ago, if you had a lump in one lung and another lung, we'd say, sorry, that's it. Nowadays, we will treat both sides and we will get outcomes that are pretty good. They're not as good as just having one cancer in one lung, but they're better than a death sentence. So we're treating more complex cases. There's a lot more involved in terms of working up these patients. You need to be able to have quick access to scanning, imaging, PET scans, pathology, surgical. We video conference in weekly to an MDT from the oncologists, the thoracic surgeons, our pathologist in another site in another hospital, ourselves in a room. Moving these people around, very expensive, not feasible. We've got the national centres, as I've outlined, so we've got movement of patients and flow around there. We've got the reorganisation of services where hospitals were rationalised and moved to the big super hospital in Scotland, and the impact it had on emergency cases coming into our locality who were managed previously in Glasgow, so you didn't have access to the paper case note, the electronic case notes, electronic data previously, so you were working in the dark. So you could get some really sick people coming across the boundary and not know what's been done before. Patients don't think that way. They think we know everything. They think we're sharing already. They don't understand that I can't see what happens on another health board until relatively recently. And patients will vote with their feet. They will go to the place they think they can get care and service and park before they'll go to where you want them to go. People are people. You can nudge them, you can poke them, you can prod them, they will decide what they want to do. So, I'm going to give you an example here. So if you think back to that map, I had a lady who came in a year ago. She lives in Clarkson, which is just across the border in Glasgow, but she came in as an emergency with a respiratory complaint. And I saw her as an acute patient. And she expressed a preference to be seen by me in my clinic. Great ego boost. No, it's the parking. It was the parking, it wasn't me, it was the parking. And our GP records and investigations that had previously been done were all in the Glasgow system. So this is a patient who, at the time that I saw her, we didn't have portal-to-portal sharing. All the conversations I had were entirely by correspondence with her Glasgow GP and asking for access. I had to get her private scans brought across, put into our system. These are the kind of things. We can't do anything about the private sector. We can do an awful lot about the NHS. So she had an ongoing respiratory problem that I won't go into, but it was enough to cause her distress and concern. And the GP was actually on the ball and very proactive about keeping in touch with me, often with diagnoses which I didn't understand where he or she was getting from. And that gives you an example. I've redacted her name, but that gives you an example of what our portal view looks like. Okay? First step here is I can see, and this is one of the things, I can see what the visits and the encounter history is. And immediately I can look through that and I can go, okay, right, I can see what they're coming to see, but why is she going to see ENT? Right, I've got to now go and have a look at that. Why have they gone to see that? Or if they've gone to see a cancer specialist, what's happened there? The first view you get, you immediately think, right, I'm reading it. You're reading the runes almost. Not tea leaves, but you're actually being able to read what's happening to the patient. That's the view we have. We have scanned all our forward notes. We actually scanned our legacy notes as well, but don't go into that. That was pain in itself. And what we can do is we can just drop down and we can see the correspondence. Something you're aware of, but we actually can dig into that from the patient view that can say, look, I'm going to look at the ENT notes, I'm going to look at these correspondences. You're starting to get a picture. Doctors have always done this. Clinicians have always done that. They flick through the case notes, and as they flick through the case notes, they're forming a picture of the patient. And that's what we're doing with this system, and that's what we're doing within our system. But I want to be able to see what's happening in Glasgow. And this is what our regional portal page looks like. So it tells you to the West of Scotland Information Sharing portal page. And you might not be able to see it there, but there is the GGC portal and the Golden Jubilee National Hospitals portal screens. So I can access that, and I can see what's been said or done in those areas. So I was looking after this patient. She got better. Then the GP started to say, what about this diagnosis? Because this autoimmune profile was saying this. And I'm going, what autoimmune profile? I've not sent this blood test. And what about this diagnosis? Because I think this is what this test shows. And I went, she'd been seen by a rheumatologist. Oh, penny dropped. It was all in the Glasgow portal. She'd been seen by a rheumatologist in the Glasgow portal. She'd had another diagnosis that wasn't related to her respiratory condition, but the GP was querying, could it be? So I was immediately able to look at that, look at the results, write back to GP and reassure them, I don't think that's the case. Patient was reassured at the next clinic visit because I was able to clear up what was confusion for her. This rheumatologist is saying this, my GP is saying this, and you're saying that, and the ENT doctor is saying another thing. And I say, calm down, this is what it is all about. Fine. Patient's happy. To do that previously, I wouldn't have known any of that information. I'm sure you can see that that's quite clear. I'd have been a bit in the dark, or very much in the dark. That's the information that I could see there. And these are just test results that immediately, when I looked into those test results and some of the correspondence from the rheumatologist, I could tell what was happening. So I don't need to put up the letter because it just gives you content. Let me give you another example. So we see patients with lumps in their lung, and they're not always lung cancer. And we see patients after thoracic surgery. And this gentleman, again, which has been modified, but based on a real patient, came in following removal of a bowel cancer. She had liver metastases, which were resected. Now, previously, if you had that, that was it. And this is highlighting how care has moved forward in other areas, not just lung cancer. Removing those metastases improved the outcome. May not cure the patient, but will improve the outcome. Then they noted that there's a couple of nodules in the lung, and he had those removed as well. Because if you remove those metastases, your outcome improves. You may not be cured, but you will have more time and more quality, which is what it's all about. But he had a problem afterwards, and he was admitted under me. So all I knew was, this is what happened in a cancer MDT. This is what had happened here. Patient wanted to know what happened in the Glasgow system. And because I had access to the portal, I could say, right, okay, you've been to the Golden Jubilee, you've had this surgery, I know what surgery you've had, I can immediately see why you've had that surgery. Where's the pathology report? It's not there. Oh, yeah. Goes to Glasgow, doesn't it? Just looked up the pathology report in Glasgow, found out that unfortunately he had lung metastases, but they had been removed, so his outcome was probably going to be good. So I was able to tell the patient and reassure him that day. Not to wait a week, not to wait a few days, but to tell him that day what the outcome was. That he had an infection, that he was going to get better from that, we could send him home 3 days later, and we did. So he knew that day what the outcome was from his surgery, and he was very worried about it. So I was able to offer that reassurance. So those are examples about what I can do from portal to portal access. What I'm going to talk about now is we have now, nearly since the beginning of the year, had access to the GP record. Now, that was a major undertaking in terms of information governance and being able to reassure GPs because they are Caldecott guardians. And they are responsible as data controllers. So if there is inappropriate sharing, I think it is £150,000 or 4% of their turnover, whichever is greater, is the fine. So it was apparent if we could get access to the GP systems in secondary care, it would be a nice massive boon. We've given the GPs access to the clinical portal because we're in a health board. They are independent practitioners, but they work under the health board. They're not in the English system with CCGs. So it's slightly different. They're under one chief executive, if you like. So it was technically feasible because majority of the GPs in Lanarkshire are on the Vision 360 system. So the summary page would be technically easy, well, relatively easy, I'm going to say, to put into the portal, to view in the portal. But it took an awful lot of hard work by my GP colleagues, Bill Martin, Bruce Thompson, two of the eHealth clinical leads on the primary care side, to make this happen, along with Phil McMenemy, who is Associate Director and GP and was Information Officer for a period of time. And it took a huge amount of work from them to get this project going, and then a huge amount of work to do the patient engagement piece, both in the practices, posters, in the hospitals with banners and tables there for people to come into the atrium and say, tell me more about this. So they engaged with the patients, and they got data sharing agreements with local GPs. But still there were problems. There were concerns around information governance and culpability if this information wasn't shared properly. So what did it take? Needed sign-off by a chief executive. And what did that really mean? As it always means, signing a bit of paper saying if anything goes wrong, we'll take the can. So, but I can assure you there were some caveats on that. Like every clinician, every individual's got their own professional responsibility. So with that access, we have another port of call in terms of trying to work out what's happening. So GP saw a patient of mine who had a long history with me, cancer resected, was fine afterwards, had some lung disease, and got some sputum results following a chest infection that had him concerned about a fungal infection, which is a really serious undertaking. It kills people really quickly. But I knew this patient, and I thought, that kind of fungal infection is unusual. It's probably a contaminant. I'll see him in clinic. But I could go in through the GP patient summary tab and see what was done in primary care without having to phone up the GP. And again, we've got the consent banner, which will allow me to access the GP record. I've redacted a lot of the other clinical information there because there's no need for that, but just to give you a flavour that we can see the past medical history, and that's the first page of the past medical history, and that's the second page of the past medical history. But more importantly, on that front page, you can also see the acute medication. And thankfully, he hadn't started the patient on an antifungal, which would have been a bit of a problem. I can see all his other medication, and you can see the other banners at the top. I'll flick through. So you can see all the medication here, past medication and medication issues. Now, the medication issues for a chest physician is phenomenal because we see patients with asthma and COPD, and we give out these things called inhalers. And these inhalers, if you add up the cost every year, are very expensive. And GPs will come and see you and say, oh yeah, doc, I'm using that inhaler. Yeah. But if you look at the medication issue for some of these patients, you can see, well, you've not picked up that inhaler for 3 months and they only last 1 month. Let's have a conversation. But in this case, I could see what had been given. So he hadn't had any antifungals given. I could see if he had any allergies, which he does have some problems with allergies and beta blockers. And I could see what had been done in the past just in case there was anything that I was missing. For that patient, I was able to move things forward very quickly, reassure him, and he's getting further tests. So it eases the interaction with the patients. It facilitates clinicians' workload. It makes it easier for them to actually work out what they're going to do with the person in front of them, and makes it quicker and more effective. And the patients like it. They feel reassured that I know what's going on with them because I've got access to all that information. So the question is, the proof of the pudding is it being used? So I've only got data for the last 6 weeks, and I'm sure Sally and the team will give you data that's a bit more extensive. I'm not going to go into that area. But if you look at the access of portal, and down here, the blue, so that's Greater and Glasgow and Clyde and Golden Jubilee that have come into us, looking into Lanarkshire, because it's a two-way street. So you can see there's traffic coming both ways. Golden Jubilee week-to-week traffic is going to be slightly less because it's much more specialised patients. But looking at the number of patients that are being looked at weekly, we're talking about between 1,300 and 1,400 accesses a week. Looking at our access to their portal, it's about 1,700, going up 2,000. It is around about the 1,800, 2,000 mark. And again, accessing into the Golden Jubilee, you can see on a regular basis. And that's specialist teams, cancer MDTs, orthopedics, etc. Cardiology. If you look at the GP access data though, we're talking about, now this fell across a holiday period in our neck of the woods. So it dipped up and going back up again. About 4,000 a week. So access to the GP systems has made a huge impact to day-to-day care. So has it been plain sailing? I think you can get the feeling that it hasn't been plain sailing. It's been challenging. Much of the heavy lifting has been done by the technical teams around the portal to portal. Around the GP sharing, that's been done by my GP colleagues. But when you look at the portal system itself, we've had some challenges in Lanarkshire, not least because we've had a little thing called a cyber attack. And when everything goes off, switches off, you suddenly know what you're missing. And sometimes the infrastructure doesn't work as quick, especially when you've had to rapidly patch things afterwards, so things run slow. So the user experience isn't as good as it should be. And that's when you really hear clinicians gripe. So it tells me one thing, yes, it's not acceptable when you have to wait to see some information. And two, it tells me they really need that information because they would otherwise go somewhere else. I've actually said, so it's unlike paper. We've got access to much, much more than we would have with paper. That we're not wasting time phoning people or they're having to speak to us on the phone, our secretaries are not having to. We're doing it all ourselves because we've got access to it. I have actually said, question mark on impact on care, because to me it's obvious there's an impact on care. To you it's obvious an impact on care, but actually measuring that impact on care, that's a tough one. So I've been in meetings with our chief exec, so he wants to know the ROI and can you prove it, which is fine, that's his job. But I think only time will tell what the impact on care is, and that will be the tough one to actually measure. And I think that's one of the things we are not good at, is measuring these things. And I don't think we're very good at it across the world in the literature as well. Our evaluation of things is not good, and we need to get better at it to actually justify we're spending all this money on this stuff. And I think you get the idea that clinicians now are becoming much, much more forensic about how they're utilising the information. They're going in search for it, they're getting the hints, they know where to go, and then they put together that picture. So the future. So I'm not going to steal anyone else's thunder because you've heard some of the pieces that have been said earlier in the day, and Sally and the team are going to be speaking about, and Jerry are going to speak about some of the stuff from Golden Jubilee. But one of the major things is going to be social care integration and beyond. Now we've heard some of the work that's been done down in the southwest. We've heard the stuff from Ireland, but the challenges will still remain of how you're going to have that proper integration of information that we enjoy in healthcare across the piece. And I don't know whether that's going to be possible without a fundamental discussion with our citizens about what it means to own that information, what the use of that information is. So that's where the information governance comes into that. But there are other challenges as well. How are we going to deliver healthcare for the next 10 years, let alone the next century? And that is it. Do we put patients in control? Do we put patients in control of their disease or their health? Do we have appropriate and robust health literacy so patients understand that you have true co-creation of healthcare plans? That you can actually have patients empowered to make decisions about their information governance themselves, give them the ownership? These are discussions that we need to have if we're going to move forward.